Okay, so I'm going to talk about bifurcation. I'll skip some slides because you are really very expert and I don't think you really need all the lecture. So I think to me this is an old slide, but it's still very important. So first you define if it's a true bifurcation. If it's a true bifurcation, no, I believe provisional is a standard. Keep in mind this strategy just to place a wire in the side branch in order to keep it open and do nothing. If it's not a true, if it's a true bifurcation, means the side branch is diseased, then the rule is dictated by the side branch. The side branch is the chief in the bifurcation. The side branch is a commander. Because if the side branch is diseased, diffused, 5 millimeter, 10 millimeter, you make a number, then you go for 2 stents. If the side branch is only focal, then you go for provisional and you cross over only if you need. I think this is all. I could finish my lecture here. There is nothing else to say that the side branch is a commander. So the approach is dictated by the side branch because you always place a stent in the main branch. Look at some examples. This side branch is focal, is important, but is focal. Then what would you do? Of course, 2 wires. Someone say.
Do you prefer to predilate the side branch and then no stenting the side branch? Because sometimes if wiring is difficult and you are not putting in your mind that you're putting 2 stents and then even 1 stent strategy. So I know that's speculation. The side branch, some dissection, crossing is difficult. But these side branches, osteogenesis 99% and ejection fraction is 20%, so it is an important lesson. We end with 1 stent, but for me, I will open this side branch for significant angle. Or if the right problem is completely normal, I will go for 2 stents for the beginning.
Okay, so definitely, unless you are bored and you want to exercise, you have to predilate the side branch. Because if you don't predilate the side branch, when you do something on the main branch, the side branch will occlude, and then you're going to have fun to recross the side branch, and maybe with the low ejection fraction, the patient is not going to tolerate because this is it's not a small side branch. So maybe this case, you will go with 2 stents based on the clinical conditions, not on the anatomical condition. Here they did not do like that. They went and then they went with the balloon, they did kissing, and at the end the side branch occluded, patient had hemodynamic compromise. Thanks God the wire is still there, so they were able to recross and place a stent. But maybe the drama would have been a little bit less if they went with two stents. This is another example. LAD, this side branch. What do you do on this side branch? Yeah.
So I think with this angle, it's quite a big why not 2
But this is very, very small. Eh? Oh, the other one, yeah. No, I'm talking about this one.
This one, no.
This one, you just keep it open. I like the keep it open because I always tell that you should finish the case with the same number of vessels you started. So I don't like to prune vessels. So in order to keep the same number of vessels, you put a wire. Usually keep... Yeah, you wire this branch and you do nothing. This branch is not a trivial branch. Look, bifurcation, big diagonal, this is definitely 2 stents. This is definitely 1 stent, no question. Superfocal, no question. This branch is very large, diffuse disease. This it's okay, maybe you can evaluate after pre-dilatation and then decide. It's not such a super branch. Again, you don't want to close, but maybe you don't do with 2 stents. This is funny. This is good for provisional, but it's so difficult to get a wire inside that maybe you go with 2 stents just based on the technical difficulties. So, as you see, sometimes decisions have to be made. This is a patient with low EF, the circumflex definitely need to be stented, the left main needs to be stented, the LAD will need stents, so it's a lot of work. I think 2 stents in these complex bifurcations are the rule. So let's move quickly because everything else is standard, just procedure. They did with impeller, but you can do with balloon pump. I will still use balloon pump. I will not do without because it's a trifurcation, a lot of action, and patient has a low EF. So, but definitely 2 stents and very good result at the end, but a lot of work. So I would like to conclude that say no 2 bifurcations are identical and an individual approach is appropriate, with some general rules dictated by the first slide, but again, every bifurcation needs to be evaluated. And I like sometimes to make the decision after side branch pre-dilatation. The side branch pre-dilatation tells you where the wind is going. If the side branch pre-dilatation gives you an excellent result, you continue with provisional. If the side branch pre-dilatation gives you a funny result, you know already that you have to go crossover from the very beginning. So strategy is also determined by the size, important extent of disease of the side branch, and I would add here by the conditions of the patient, which is not here. The provisional strategy is appropriate in the majority of true and non-true bifurcations, but the wind is a little bit changing. You see that with the DK crash 5, especially for left main, there is a shift more towards more use of 2 stents. A few years ago, if you implant 2 stents, you were accused. Now, I believe this strategy is more toward 2 stents. About 20% of bifurcation require 2 stents. In the 2 stents technique is very important to optimize. If you have IVUS, is best, but if you don't, you have to accept at least a very good angiographic result. Then I have some 2 cases, but I like to go first with You know, I do final kissing with the stent in the with the balloon in the side brain protruding so I do like a hugging balloon, and this is my pot, pot with hugging balloon. I thought that pot was something related to Pol Pot in Cambodia. I didn't know that. Anyway, I want to show you a simple case, but this was recorded a few days ago in Cotignola. So there is a comment, but I tell this is an ostial circ. Again, let me stop. How do you stop? Okay, here. Yeah, stop like this. So what do you do with this ostial circ? Pure ostial circ. Yeah, stop here. Stop, perfect. Pure ostial circ. This is a bifurcation lesion, ostial lesions. I bet you place a stent precisely at the origin of the circ. That's the most common approach.
What's inside the left vein? If you don't have an IVUS, if you have an IVUS, it's okay, you can see it is the left vein. You have to decide with the wire with then crossover and then kissing and see what's flashing LED, FFR, or anything less than 25. If you don't have an IVUS, you should end by only precise technique of the sales.
But you know, anything you do with the stent here, the restenosis is very high.
Yeah, opinion of the
sometimes we make that alone with that while putting the stent, maybe make it more precise. What do you do to say it's precise osteoarthritis?
But let me. So we have pre-dilated the lesion with a 2O balloon to do IVUS. The IVUS is done to learn about the vessel size, only to know about the vessel size. Because this vessel looks a 3O, but maybe is a little bit bigger. Okay, so he's pre-dilating with a 2O balloon. Not such a big deal. It's okay. Okay, so now after pre-dilatation with cutting balloon, they do IVUS. This is after the pre-dilatation, only to do IVUS. Nothing more. Is flashing the IVUS. So this is the IVUS. So there is a distal circumference, 1, 2, 3, is almost a 3.5 vessel. This is close to the very, very focal, superfocal, not very, this is the left main, not very calcific. So very focal, not much diffuse disease. So what we learn is that shockwave balloon, absolutely not, because it's focally calcific. Rotablator, forget. Stenting you can do. Cutting balloon is what we did. To dilate better, only fibrotic, we took a 3O cutting balloon. This vessel is 3.5. As I said, we take a 3O, protrude a little bit in the left main, and inflate at 22 atmosphere. Good solid inflation, 22 atmosphere, undersized cutting balloon. "20 seconds, I always like to do 20 seconds inflation, or 30 seconds, not up and down. Just, okay, this is after cutting balloon. So stenting or drug-coated balloon. In this case, we decided to do drug-coated balloon. We repeated the IVUS to make sure. So this is a more distal vessel. It's about 3/0 vessel. Some plaque here, but not much. Getting towards the ostium. And this is the ostium, which is not bad at all. This is the left main already. So after this, I believe we are more convinced that drug-coated balloon is an acceptable choice. So we take a 3.5 drug-coated balloon, and we inflate the drug-coated balloon for 45 seconds. So the lesion is here. We do a little bit of massage here at the end, but the ostium looks really nice. This is just a final touch. I don't think it's necessary, but just to make things look a little bit better, with the same drug-eluting balloon, 3.5, low pressure here. Here we inflated at 10 atmosphere. Okay, and this is the final result. No compromission of the LAD. And I think we do a very final IVUS, but basically he says the same. And we give the stent to the patient to keep in his wallet. He goes home with the stent in his pocket, but not in his coronaries. So I think I have nothing against to do stenting here, but I think it's fine, it's the same. My only concern is the high rate of restenosis. We have seen a lot of restenosis as the ostium of the circumflex. There are no studies. I wish we can do a prospective study, but the key in decision making is the result after predilatation. If the result after predilatation is good and stable, you may just hang there, go make a couple of telephone calls and come back and see. If you have stability in 10-15 minutes, that means that the result is stable. The recoil, I think we have seen that the drug on the drug-coated balloon prevents or keeps the recoil minimal because tends to give a positive remodeling. So I'm not afraid of recoil unless you have acute recoil. If you have acute recoil, that's a different story. But the way to prevent recoil is to do an aggressive predilatation. And you are not afraid to do an aggressive predilatation because you have a stent available. So you are not afraid to place a stent, but you are afraid to do a good job at the beginning. So if you do an aggressive predilatation and you have a dissection, fine. That's your goal. You are happy to place a stent and you place a stent. But if you have an aggressive predilatation and the result is good, then you are clear not to place a stent. One-to-one, except with a cutting balloon at high pressure. With the cutting balloon at high pressure, we undersize because the cutting balloon at high pressure is compliant and then becomes one-to-one, but because I go to high pressure. I dilate one-to-one because my goal is not to place a stent. My goal is to have optimal predilatation without being sorry if I have to place a stent. I think it depends. If it's like this, where the left main is pretty healthy, I prefer to go precise. Precise means maybe a little bit of protrusion in the left main. And which projection you will take in this case? I take two projections. I take very caudal RAO, very steep caudal RAO, and very steep spider.
If you have just focal lesions and it is wiser to use dilation most the provisional one or pre-dilate also the focal side. If you have a side branch, a focal lesion in the side branch, less than 5 millimeters, you're going for pre-dilation?
If it depends, if it's very tight, yes. Because, because I am afraid that when I treat the main branch, the side branch will occlude and then I have difficulty to recross. Maybe I don't do an aggressive pre-dilatation if my intention is from the beginning try not to stent. Sometimes if I have a diagonal which is 2.5, 2 millimeter, they say it's better not to stent, I do a conservative dilatation, just to facilitate recrossing. Okay.
Stent crossover left main CX and LDLA. Are you allowed to make it and do an FFR for any either side branch and to leave it? The same concept like stent from left main and doing FFR to CX or anything that others are doing?
No, I think it's okay. I think I'm not very enthusiastic to do crossover left main circumflex unless the LED is really in good shape, because I'm always afraid for the LED. But if I do that and I do FFR and the FFR is 0.9, has to be really good, I think it's fine. But I think if I don't do FFR, IVUS or very excellent angiographic result.
Okay, thank you very much, Antonio.
Thank you.